Hi, Shireen. Tell me something. How do we risk stratify patient with essential thrombocythemia and polycythemia vera in the clinical setting?
So that is something that also we are learning more and more about. Initially, our risk stratification was based on age more than 60 in a previous thrombotic episode, that having one or both of these placed a patient with PV or AT at a high risk. For polycythemia vera, this is still the most commonly used way of stratifying patients. However, we are learning more and more about the disease, and now we know that having a white blood cell count also places the patient at a higher risk of thrombosis. We also know that there are other contributing factors, such as possibly the JAK2 allele burden, the higher places patients at higher risk of thrombosis. For essential thrombocytosis, we do have some other risk scores that refine the high risk versus low risk, and some patients are even end up with these scores being at a very low risk or an intermediate risk. These scores still integrate age and a previous history of thrombosis, but also take into account cardiovascular risk factors such as hypertension, diabetes, all of the things that are classically known to increase the risk of having a heart attack. In addition, they integrate the presence of the JAK2 mutation to add to the higher risk category.
Similar to your practice, our most commonly used score to assess the risk of thrombosis is simple score like age more than 60 years or previous history of thrombosis. Patient who have either risk factor is high risk, patient who have none of these risk factor low risk. And in ET patients, we have started using more commonly new score, IPSET score, which is also known as International Prognostic Scoring System for Thrombosis, which take into account the presence of JAK2 mutation and cardiovascular risk factor, as you mentioned. Now, in terms of treatment decision, how do you decide in PV and ET patient, what is your approach to patients with PV and ET, let's say low risk patients?
So, just to emphasize that these prognostic risks that we discussed are risks for thrombosis, so developing a blood clot. So, our aim for our patients with ET and PV is to reduce that risk. A patient at low risk usually does not need to be treated with medication that reduces their counts, the medication that we refer to as cytoreduction. Most of the time, for these patients, we treat them with low dose aspirin, and that is sufficient.
Yes, I agree. It's low risk patient mainly get aspirin, and in polycythemia vera patient, depending upon their hematocrit, this patient also be candidate for phlebotomy to keep your hematocrit below 45, and the high risk patient will go for cytoreductive therapy. Are there any circumstances where you would consider cytoreductive therapy in low risk patients?
Yes, the diseases don't tend to read the books, and every patient is different. So, for example, in essential thrombocytosis, one of the common reasons where we would start a patient with low risk disease on cytoreductive therapy is that they may develop bleeding tendencies. So, contrary to what we think is that the higher the platelet count is, we think intuitively that might cause more clotting. Actually, the higher the platelet count is, sometimes patients develop dysfunction of their clotting systems, which we refer to as acquired von Willebrand's disease. And these patients are more at risk of having bleeding rather than clotting. So patients who have that, we tend to give them medication to bring their platelet count down so that we mitigate this risk of bleeding. In addition, there are patients with PV and ET who might have these, what we refer to as microvascular symptoms, migraines, headaches, burning in the hands and the feet, that may improve with aspirin, but in some cases may not. And sometimes for these patients, we are more likely to give them cytoreduction to see if that can help. Speaking specifically about polycythemia vera, many of our patients don't tolerate phlebotomy very well. Some of them with the development of iron deficiency develop more severe fatigue with that, develop symptoms that are complications of iron deficiency, such as restless leg syndrome. And therefore, phlebotomy becomes quite a burden on them in terms of symptom control. And in this case, we may consider giving cytoreduction in order to alleviate the side effects of phlebotomy and iron deficiency.
Yeah, I think our approach is very similar, case by case consideration for cytoreductive therapy in low risk patient and consider cytoreduction therapy for high risk patient. So, what are the commonly used? What are the options you provide to your patient for cytoreductive therapy? And are there any of the agents used for cytoreductive therapy are your favorites?
So, common to both ET and PV, I believe across Canada, the most common first agent for cytoreduction is hydroxyurea, which is effective in bringing the hematocrit and the platelet count down. For essential thrombocytosis, we also have anagrelide as an option, and we also have interferon. So, Pegasus is one of the agents I use a lot in my young patients. For polycythemia vera, it's the same thing in terms of starting out with hydroxyurea. And we also have approval in second line for Jakavi or ruxolitinib for patients who are resistant or intolerant to hydroxyurea. We do also still use Pegasus in our low risk patients. And there is hopefully a new option coming to Canada, which is a long-acting interferon called Ropeg that we're very hopeful we would have access to in the near future.
Yeah, I agree that there is a increasing use of interferon as a choice for cytoreductive therapy, and Ropag interferon has been approved for patients with polycythemia vera by FDA as well as some European countries. It's not approved at present in Canada, but we hope that the approval for Ropag interferon will come in Canada, which will be a good news for Canadian patients. Are you excited about any other investigational drug which are on the horizon for PV patients?
Yeah, so there is a drug that targets the iron metabolism pathway. It's a hepcidin mimetic. It's called rusfertide. And that works in terms of, you can kind of think of it as a chemical phlebotomy in a way. So it brings the hematocrit down and normalizes the iron levels in the blood, and that is an exciting option for patients who may not tolerate phlebotomies but may not want cytoreduction, or for some of the patients, also been studied in patients who are on cytoreduction and still requiring phlebotomy.
So, Shireen, are you any of the cytoreductive therapy options we have at present? Do any of these options reduce the risk of PV or ET progressing to myelofibrosis or acute myeloid leukemia?
Unfortunately, we don't have any definitive evidence that any of our cytoreductive agents succeed in reducing the risk of progression to myelofibrosis. There have been some analysis of trials that showed a possible correlation between reducing the JAK2 allele burden and a lower risk of progression to myelofibrosis. And this has mostly been shown in trials with the interferons. It is a possibility, but it is not a definitive evidence. However, many patients do feel that that possibility is something they would like to explore, and therefore, many of them do like to have their JAK2 allele burden followed if they are on an interferon.
Yeah, one of the main issue we have in our setting is we do not have Ministry of Health funding for repeated JAK2 allele burden testing to follow. So I agree that there is no convincing evidence that any of the current cytoreductive therapies reduce the risk of transformation to myelofibrosis or acute myeloid leukemia. But this is something we have to study from the long-term data from the ongoing studies. And the main goal of current treatment is reduce the risk of cardiovascular complication by mitigating the risk of heart attack or stroke.